Whenever a patient stops taking an antibiotic, it has to be eliminated from the body. The length of time that takes is based on an antibiotic's half-life. If you take a look at azithromycin, it has a half-life of 68 hours. When you take a look at clarithromycin, it has a much shorter half-life, typically about 6 hours. Any antibiotic, once it starts to become eliminated from the body, you end up with subtherapeutic levels of drug in your tissue and your serum. During that time, you're at increased risk for the selective colonization by resistant strains. So with a drug like clarithromycin, with a relatively short half-life, that window of risk is very short, perhaps 6 to 10 hours. The problem with a drug like azithromycin having its 68-hour half-life, once that patient stops taking that drug, that patient is liable to have subtherapeutic levels of drug in both their tissue and serum for almost a week. In other words, that patient is at risk for the selective colonization by resistant strains for approximately 4 to 5 days versus 6 to 10 hours. Clarithromycin is the antibiotic of choice because of the types of levels that it achieves in vivo. If you take a look at epithelial lining fluid, clarithromycin hits a level of approximately 40 compared to its comparator, azithromycin, which hits a level of approximately 2. If we look at serum levels, clarithromycin hits a level of 2 to 3 versus azithromycin, which hits a level of 0.1. If you're trying to treat mucosal disease, like community-acquired pneumonia, acute exacerbations of COPD, the organisms primarily responsible for those particular disease processes are mucosal. Streptococcus pneumonia is not an intracellular pathogen. Haemophilus is not an intracellular pathogen. They are mucosal pathogens. And as such, the type of levels that you want to achieve are found in the epithelial lining fluid. So 40 micrograms per ml for clarithromycin versus 2 micrograms per ml for a drug like azithromycin. The latest guidelines advocate potent drugs to manage your patient. What they're not advocating is using broad-spectrum potent drugs like fluoroquinolones or carbapenems. What they're suggesting is that you stratify your patient, decide on the most appropriate class of antibiotic to use, and then use the best or most potent antibiotic inside that class. We recognize that for any given class of antibiotic, there are a number of agents inside that class. And we know now through in vitro data, in vivo data, pharmacokinetic data, that these agents are not all identical. As such, when you decide to use an antibiotic, decide on what is the most appropriate class of antibiotic, then use best in class or most potent in class. And by doing so, you can minimize the selection of resistance.